We're going to start Chapter 10 now. Chapter 10 covers Medicaid and Medicare. This is Medicaid. It's the first of two lectures that are going to focus on government insurance. And so this first one is on Medicaid. Part 2 is going to be on Medicare. But just as a digression, remember government also pays for coverage in a lot of other ways. They pay through Veterans Affairs for veterans of foreign wars who have returned home. They pay for active duty military and families through TRICARE. You may have heard Champus, that was the former plan. They pay through FEHB, the Federal Employee Health Benefits, for anybody who's actually employed by the federal government. And then all the local government entities, counties, cities, states, they have employees and dependents as well. And so they have coverage for their entities, their employees and dependents as well. And so government in some form pays for insurance for a large fraction of our population. Medicaid covers low-income Americans. And, you know, you've heard my tongue trip up during lecture all the time. It's really easy to get Medicaid and Medicare mixed up. Medicaid is low income, Medicare is elderly. And so we're talking about low income insurance in this lecture. The cost of Medicaid is split between the federal and the state budgets, and we'll talk about that a little more in a little bit. The actual coverage varies by state because the federal legislation defines minimum coverages, but different states may be a little more generous or not. Basically, eligibility, minimum eligibility defined by the federal government is if you are eligible for TANF, that is Temporary Assistance for Needy Families, colloquially called welfare, or SSI, which is the Supplemental Security Income for the Disabled, people who are both poor and over 65 or blind. If you're eligible for one of those programs, you are eligible for Medicaid. Alternatively, if you are a pregnant woman or if you're a child under age 6 and your income is under 133% of the federal poverty limit, then you're eligible for Medicaid. Any kids who are under age 19 with income under 100% of federal poverty limit, they are eligible for Medicaid. And then ACA reform in the states that adopted Medicaid expansion added all individuals, whether they are kids or adults, with a federal poverty limit under 133% of the federal poverty limit. What's the scope of coverage? How important is Medicaid in our population? Well, 45% of kids are eligible for Medicaid. Now, only 18% of the dollars spent through Medicaid is for children. That shouldn't surprise you because kids are cheaper, right? They get wellness benefits and things like that, but they don't have chronic illnesses typically unless they have, childhood or congenital diseases. 22% of adults in families with kids are covered through Medicaid. 14% of the dollars spent by Medicaid are for parents with children. Again, they tend to be a little younger and not as sick compared to the next two categories we talk about. 14% of the disabled have Medicaid coverage. 43% of Medicaid's dollars are spent on the disabled because they're pretty sick, right? And finally, 7% of those aged 65 or older are eligible for Medicaid, and 20% of the dollars spent under Medicaid are for those aged 65 and older. So even though the number of people is really heavily weighted toward kids, it's the disabled and the elderly who are spending the majority of the dollars. Shouldn't surprise you. How is Medicaid financed? Well, I just mentioned a minute ago that financing is split between the state and the federal governments. Prior to the scope of Medicaid, that is the pre-ACA piece, that is split based on the state's per capita income. Basically, richer states pay more. So if you have a high per capita income, your state will pay close to 50% of the cost, with the feds paying the other 50%. If you have a really low per capita income, then maybe your state will pay only 20% or 30% of the cost, with the state paying 70 to 80, with the federal government paying 70 to 80% of the cost. The ACA expansion portion, which extended scope of coverage to adults under 133% of the federal poverty limit. Just that adult population, that new adult population, is paid for 100% by the federal government in the first 3 years of the Affordable Care Act. That phases down to 90% federal, 10% state for the years 2020 and later. But that still is a really large fraction of the cost being paid by the federal government in perpetuity. Let's look at Minnesota specifically because states vary so widely. We can't really look at all different states. I can talk to you about minimum eligibility, but with the Affordable Care Act expansion and the variety there, and some states choosing to be more generous or less generous, this is where we are in just Minnesota. So if you are an adult without children, or your parents of eligible children, you get coverage up to 133% of the federal poverty limit. And that first category, adults without children, that's that eligibility under the Affordable Care Act. Kids under age 2 get covered up to 283% of the federal poverty limit. From 2 to 18, the limit is 275. 19 to 20, it's 133. Pregnant women, it's 178. Elderly and disabled, now this is a key thing, it's only 100% of the federal poverty limit, plus you have a limit on assets. You can only have $3,000 in assets. So when we talked about long-term care and we talked about spending down your assets to get eligible for long-term care under Medicaid, this is what we're talking about. If you have maybe a nice little nest egg for retirement, and so you have $50,000 sucked away for your retirement, you're going to have to pay out all of that $50,000 on your long-term care and erode those assets down to $3,000 before you can get Medicaid to start to pay for your long-term care. But also just general health care, where we're talking about here, not long-term care, but general medical care under Medicaid. You have to be elderly, you can't earn more than 100% of the federal poverty limit, and you have an asset limit. Now, Minnesota has something special called Minnesota Care, and this is a layer of coverage for those who are not eligible for employer insurance or Medicare, make too much to be eligible for medical assistance, the first part that I talked about, but you're still below 200% of the federal poverty limit. If you're in that range, you can enroll in Minnesota Care. You do pay a small premium for that, and there are some small co-payments at point of service, but it gives you an affordable option. And this has existed long before the Affordable Care Act. Medicaid provides insurance access. There is little or no cost sharing under medical assistance. If you're in the expansion into Minnesota Care in our state, there are some small co-payments. The empirical work shows that this is important because even small co-payments can have a really big price impact on the low-income population. For us, the cost of a latte that we may not even think about could be the deterrent to somebody who's low income to going to get needed care. Access to providers as opposed to access to insurance, that's a different matter. Under Medicaid, you may have trouble finding providers that will see you because providers may limit the number of new patients they take on because of the low reimbursement rates. Medicaid reimbursement is often well below Medicare reimbursement, so the fees paid to providers could be quite low. Kaiser has a nice Medicaid to Medicare fee index that they update every few years. This is their most recent statistics, their 2012 fee index. And so I'm showing you some selected states here on the low end. Rhode Island, New Jersey, California, they pay only 37 to 51% of Medicare reimbursement to the Medicaid providers, or for individuals who go see a provider. So in Rhode Island, if I'm a doc and I have a large fraction of my practice that is Medicaid eligible, I may have trouble staying in business because the reimbursement rate is so low. So I might limit my practice to a very narrow segment of the population, my practice population being Medicaid eligibles. So access to insurers in those states may be very difficult. Minnesota's in the middle of the pack at about 71%, so Medicaid is about 30% less than Medicare fees. On the high end, Oklahoma, Wyoming, Alaska, North Dakota, they actually pay at or above Medicare fees for their Medicaid reimbursement rates. Our last slide talks about Medicaid crowd out. This is a concept that you may not have heard before. The theory is if we offer free coverage through Medicaid, then people who would have been paying for insurance on their own might drop that, and now the government's left holding the bag providing coverage for them. And that's what crowd out is. If we offer this free thing, then it's going to crowd out coverages that people had to pay for. Well, certainly that can happen at the individual level, and it's not surprising it happens at the individual level because these people are really low income. And so if they suddenly have access to Medicaid, why would they continue to purchase coverage on the private market on their own when they can just drop that coverage and get enrolled through Medicaid? I mean, they might, because some people have trouble with the stigma of a low income insurance. They view that, they put a stigma around that. Some might be aware of the limitations of access to providers through Medicaid and prefer to have private insurance. But boy, those things would have to be really, really important to somebody if they were low income to make up for the difference in free coverage versus paying a premium. The more subtle one might happen in the case of employers. Employers might have a low wage workforce where a large fraction of their workforce would be eligible for Medicaid, and so they may drop coverage that they're offering and rely instead on their employee base getting coverage through Medicaid. Lynn Blewett and Kathleen Call, who are two professors in our division, have done quite a bit of work on this. And they have found some evidence for crowd out, but they've found that it varied a lot by population. For example, low-income kids, the crowd out is really low, as low as 0% up to maybe 15%. But higher income kids closer to the Medicaid eligibility limits, it could be as high as 35 to 50%. Notice the 2007 date on this research. That's pre-ACA, and so it's really hard to know what has happened after that. All right, take a break and then come back and listen to part 2, which is about Medicare.